Aparna Sridhar. So ನನಗೆ ಗೊತ್ತಿರೋ ಅಷ್ಟು ಕನ್ನಡದಲ್ಲಿ this much I have laid open. So I will formally introduce Aparna to our beloved delegates in a few minutes from now. But on priority, we would like to thank Dr. Vidya Tobbi, the president of Kasoga, who is always supportive and never say no attitude, which she possesses, is taking her a long way, not only within the state of Karnataka, but across the country, across Asia, and very soon, I hope, across the globe. So this program, ladies and gentlemen, is being presented to you by the KCOG, which is the academic wing of Kasoga. And it is a recurrent program on the last Thursday of every single month and called the International Speaker Series. It's hosted by Artist, which is Asian Research and Training Institute for Skill Transfer, and always gratefully supported by the Shield Healthcare. And this time we have the privilege of having the Medisage also co-hosting this program with us. So on behalf of Dr. Divakar, the Managing Director at Artist, Sheetal, the project lead, and the entire team, I once again have the pleasure of welcoming and hand over for the opening remarks by Dr. Vidya Tobbi.
Thank you, Dr. Hema. It is always a pleasure to have such a international academicians on our board, and also I thank you for bringing them on this platform. So we all know that Kasoga is having 21 societies, and we have got so many academicians. We have given to the national level, we have got many presidents, and FIGO, the Well Woman Chair, is with us, like Dr. Hema Divakar, and we always feel that she should have a higher position to take us and discuss many programs, and she can bring many programs to us. So today she has brought very important, as she told in Kannada, and so many other delegates, my postgraduates, they may not know Kannada, but what she has told is Dr. Aparna Sridhar is 100% true. Such a true academician. We wanted to have her physically, but we will definitely invite her in one of our Kasoga programs at any of the zonal, or I invite her to Bijapur, where we are doing our state conference. She is today going to talk on hypertension, which is whenever diagnosed in pregnant women. Major issues we face are, one is establishing diagnosis, and sometimes determining the threshold for initiation of the treatment, the target blood pressure, which drugs to avoid, which has having potential adverse fetal effects, and the determining the optimum time of delivery. So I hope that these deliberations are going to help us. And then there are, she is the only a speaker. So I invite the question and answer sessions also. She can definitely clarify our doubts. So over to Hema, and I really thank her for bringing Dr. Aparna Sridhar here. Thank you.
Thank you, Vidya. All of you need to know a lot more about Aparna, and it is my very proud privilege to present Aparna Sridhar to you. She is the curriculum lead for, as I told you, she is across the border, hailing from the UCLA at California, curriculum lead for intersessions, obstetrics and gynecology at David Geffen School of Medicine at UCLA at present. Medical student, clerkship director for obstetrics and gynecology at the same institute from 2021 up till today. Co-chair of Applied Anatomy College at David Jefferson School. She has multiple hats: Health Sciences Associate Clinical Professor, Department of OLG, and the clerkship side director for obstetrics and gynecology. Above all, she is a very beloved friend and colleague, and our association began with coming face to face at the virtually at the International Organization of OBGYN, that's the FIGO, where very ably and very efficiently Aparna is the chair of the contraception committee, giving profuse amount of new ideas and infusing a new leash of activities through her committee as well. Health science assistant clinical professor and consultant gynecologist, author, ASHE Student Health Center at Los Angeles. And even though the timings may be odd for her to wake up at odd hours in the morning, she's always there for the programs within our country. And as we speak, in July, the Foxy Figo meeting will again present Aparna Sridhar to you in ground reality deliberation when East meets the West. So though she's born in India, there is a lot of difference that she would have observed during her tenure and career in the Western part of the world. So it'll be a good mix for us to know when we are struggling even to empower our frontline healthcare providers merely to take a blood pressure measurement, which is the basic thing that all the women deserve to be checked on. There is a whole range of what's new and what is feasible. The divide between the East and the West, it's a good mix for her presentation today. American Board of Obstetrics and Gynecology and Complex Family Planning Subspecialty Boards at the American Board. And if I click, I can go on and on with many, many slides, but her work speaks for itself. That's what I think about Aparna. And always, always she's wanting to do more than what she has done before. So this, ladies and gentlemen, is Aparna Sridhar talking to us today on hypertensive disorders, the diagnosis, and the time of intervention. We urge you to pen down your questions in the Q&A box so that both Medisage and the Shield team will send it to us and we will voice it out on your behalf for the expert, Dr. Aparna Sridhar, to respond to the same. Over to you, Aparna. Thank you so much again for being here with us.
Thank you so much, Hema. And thank you, Dr. Hema and Dr. Vidya, for inviting me. Thank you, Dr. Divakar. It's always a pleasure to do anything back home where I feel like I belong. As I always say, I never say no to Dr. Hema. And whenever she invites me, it's always a pleasure. So with that, I want to, I think this was a very apt and important topic, and how many ever times we actually listen to hypertension, we actually feel like, it's not enough. So that's the reason why I chose the hypertensive disorders of pregnancy. Now, I think I have no disclosure. I have to say, from being in the beautiful city of Mysore, where I was born and brought up, and I did my medical education in Mysore Medical College, to it's been a personal journey to come to Hollywood. It's Los Angeles where I live, and University of California, Los Angeles. That's where I practice. I feel like there is a whole lot that I learned in both systems. Being in India and learning about the health system over there, and also being in the United States, learning about the health system over there. It's been a great journey to learn about women's health in two different parts of the world. And I'll try to kind of share my learnings during the process with you all. So with today's lecture, I just want to make sure that we define the current terminology and understand the updated diagnostic criteria for the hypertensive disorder of pregnancy. I want to describe the management guidelines for hypertensive disorder of pregnancy, and more importantly, identify the delivery timing for various subtypes of the hypertensive disorders. I think the general references that I have for all of you is the American College of OBGYN's practice bulletin, or the American College of OBGYN, which is the counterpart of Foxy in USA, publishes these practice bulletins and committee opinions. So I've kind of taken most of my slides from that. There's also the NICE guidelines, which you all are probably aware of, which is the hypertension in pregnancy diagnosis and management from the Royal College of OBGYN. And we also have a committee opinion from the American College of OBGYN, which is medically indicated late term and preterm, early preterm delivery. So I have taken some slides from there as well. In the end, I'll actually go over some of the slides which are very action oriented. These are from California Maternal Quality Care Collaborative. This is an organization in California which aims to reduce the maternal mortality in California. And it has successfully reduced the maternal mortality in California to 6 per 100,000, which is actually the lowest in the United States. And they have some guidelines and algorithms. So I would love to share those with the audience here. And I'm happy to share that with Dr. Hema for circulation later, if anybody wants it. So the basic diagnostic criteria and investigations, I think it's pretty much the same everywhere. In the past, there used to be so many terminologies for the hypertensive disorders like severe or mild preeclampsia, toxemia, pregnancy-induced hypertension, atypical preeclampsia. But I think now the preeclampsia and the spectrum of hypertensive disorders in pregnancy, we are trying to group them all together so that there is not a lot of confusion. Terminology is only one thing, right? So we don't have to wrap our heads too much into what needs to be called, but still it's good to understand what is it that actually accurately determines the hypertensive disorder of pregnancy. But before we step into that world, I think one of the basic things that all of us need to know is how to accurately measure blood pressures in pregnancy. Accurate blood pressure measurement is essential guide to guide the management decisions in order to avoid either over-treating or under-treating, because both of them can lead to adverse outcomes. We should aim to minimize the factors that decrease the accuracy of the blood pressure measurements and be consistent, like same arm, same position, and correct cuff size all the time. A severe range of blood pressure obtained with an automated device, nowadays we use a lot of automated devices, should always be validated with a manual measurement for accuracy, because again, having the severe range blood pressures in pregnancy can totally mean a different thing. So we want to make sure that we're actually accurately measuring this. We also should evaluate the blood pressure trends and versus isolated values, because one blood pressure elevation in the 160 over 110 may not be that bad, whereas a persistently elevated hypertension may actually be a problem. So evaluating the trend is equally important. So preparing the equipment, preparing the patient to be in the right position, taking the measurement, and recording the measurements are really important before we go into the details of any of these. So getting back to the diagnostic criteria, as you all know, chronic hypertension is systolic blood pressure of 140 millimeter mercury or more, and the diastolic of 90 or more before 20 weeks of gestation, or if someone actually had hypertensive disorder and did not get it resolved postpartum, despite 6-8 weeks postpartum, you start thinking about, do these people have chronic hypertension? Whereas gestational hypertension is systolic blood pressure of same 140 and diastolic of 90 or more, but this is on 2 or more occasions, at least 4 hours apart, after 20 weeks of gestation in a woman who actually, we know, had a previously normal blood pressure. For many of us who are actually working in the facilities where it's not very clear, if you've seen this patient before, we kind of go by the first blood pressure and kind of monitor it from there. But if they do give a prior history of blood pressure elevations or something like that, it actually makes the distinguishing between the gestational and the chronic hypertension somewhat easier. One of the things that we learn is that 40% of patients with new onset of hypertension or new onset of proteinuria will kind of develop preeclampsia. So the first ever development of the hypertension is really important to document. Now, preeclampsia, on another hand, is the same gestational hypertension, which is systolic of 140 or diastolic of 90 after 20 weeks, more than 4 hours apart, or 160 or 110, again, severe hypertension confirmed within a short interval of time to facilitate timely antihypertensive therapy. But in order for us to diagnose preeclampsia, we have to have this along with either proteinuria diagnosed in different ways. So for example, in my facility, we actually do a urine protein creatinine ratio, and that of 0.3, which is equivalent to 300 milligrams of more in 24-hour urine, is considered as preeclampsia. Some places where you don't have the ability to run a protein creatinine ratio, they go by the urine dipstick of 2+ or more. It's usually inferior to other methods because the spot urine dip can be pretty inaccurate. The RCOG guidelines also talk about the urine albumin creatinine ratio of 8 milligram per mole or higher. We don't use that in the United States. Or the gold standard is to collect the 24-hour urine. You start in the morning, you make them pee first in the toilet, and then start collecting the first urine. And then again, until the next morning, the first pee actually goes in the bucket. And then we test that for 24-hour urine. And that would be 300 milligrams or more is considered proteinuria. But if you don't have proteinuria, some of the other diagnostic criteria for preeclampsia include thrombocytopenia, which is platelets of less than 100, renal insufficiency, creatinine either 1.1 or more. Remember, in pregnancy, the creatinine is always low, or double the baseline if you've had a baseline for someone. Impaired liver functions in terms of twice the normal concentration for AST or ALT, alanine or aspartate aminotransferase, new onset headache that is unresponsive to medication, any visual disturbances, usually sparks or spots in front of your eyes, pulmonary edema. Those are some of the severe criteria, preeclampsia with severe features. We have to understand that pre-existing proteinuria, like in higher amounts prior to 20 weeks of gestation, may actually suggest something related to chronic renal disease. So that could be leading to hypertension or diabetes or some autoimmune disease. So it's very important to double check, especially in those patients who have really high proteinuria. You may have to think about, is this some kind of pre-existing disease? The spectrum of preeclampsia is very variable, right? So we have preeclampsia with severe features, and then we have the HELP, which is, as all of you know, the hemolysis, elevated liver enzymes, and low platelets, as well as eclampsia, which kind of leads to the seizures. So the preeclampsia with severe features, this is kind of a way to say this is developing into hepatic and hematologic and neurologic manifestation. And also remember, HELP syndrome can occur with or without hypertension and proteinuria, so it can be very atypical presentation in some of the patients. And eclampsia, as we talked about, it's a new onset. It should not be a prior existing seizure. It should be a new onset tonic-clonic, focal or multifocal seizures in the absence of other causative conditions such as epilepsy, cerebral artery ischemia, or intracranial hemorrhage, or they shouldn't be on any, cocaine or any other drug use. So these should be very new onset hypertension. The mortality from eclampsia can be 1% in places where you have all the resources to control it and manage it, to as high as 15% where you have poor resource setting, where you have either problem identifying or managing the eclampsia. So most common prodromal neurological symptom to diagnose eclampsia is usually headaches and visual disturbances, regardless of the degree of the hypertension or whether the seizure is occurred antepartum or postpartum. Headaches and visual disturbances usually precede any of the seizure events. And 20% of the women with eclampsia actually don't report any neurological symptom, and it just happens. So you can see we could be as much prepared, but there is always these hypertensive disorders can trump our knowledge and ability to diagnose things. So when we are talking about investigations and delivery timing, and so the most basic investigations that we run are to kind of signify is there severe preeclampsia, or is this patient going towards preeclampsia? Because just the diagnosis of preeclampsia, you can actually make it with a dipstick or even just with the blood pressure cuff. But all these investigations do come into picture when you want to double check, is this severe preeclampsia? So the basic investigations, complete blood count just to check the platelets and also the baseline hemoglobin, AST, ALT, aspartate and alanine aminotransferase. We can get a CMP, a comprehensive metabolic profile, what we get, which gives you all the electrolytes along with the creatinine, glucose, AST and ALT. LDH is questionable. I usually don't get it in my clinical practice because it does not give me much of like, clinical help. Urine protein assessment, as we talked about, uric acid is very optional. I have stopped getting it because it does not give me much. Glucose can be useful because you may sometimes have to differentiate preeclampsia from the acute fatty liver of pregnancy. And then for for patients with acute abdominal pain, you may want to add like amylase, lipase, and ammonia just to make sure you're covering all the differential diagnosis. But we have to remember that 30% of the cases are actually diagnosed postpartum. 15% of the cases may not have hypertension or proteinuria. 90% will usually have some kind of right upper quadrant pain or discomfort. 50% of the patient usually have nausea, vomiting. LDH is usually really high in true help. And then platelets are usually low, like less than 100. I recently had a patient who had like 38 platelets. So this can be really important. And for eclampsia, honestly, not much different investigations other than severe preeclampsia investigation, but you can have maternal hypoxia, trauma, and aspiration. So you have to really keep in mind for like short-term and long-term neurological damage can happen, but it's extremely rare. The other forms of severe preeclampsia are the PRES, also known as the posterior reversible encephalopathy syndrome. You have temporary vision loss, headache, seizures, confusion, and altered sensorium. So if you have like someone with preeclampsia who's actually, whose mental status is deteriorating, you may want to really think about PRES. And this is categorized with the MRI, where you can see like the hyper intensities in the posterior aspect, as you can see in this picture. But that's kind of the most severe form of the, preeclampsia, usually kind of late stage. And if you haven't treated it, or like if eclampsia goes unnoticed, you can probably see these PRES symptoms in such patients. So that was kind of an overview of the investigations for both like preeclampsia, gestational hypertension, HELP. But I think when we talk about the general principles of treatment, we really have to understand the balance between the patient and the fetus. That means the risk with the severe hypertension, we have to, the complications for the patient with the severe hypertension and like the complication that can happen to mom has to be balanced with the fetus prematurity, because we can't be delivering all babies early for this. And that can actually lead to neonatal mortality and morbidity. So we really have to think about the general principles of treatment while we're actually trying to balance the two, patient and the fetus. And that's always our problem, right? As obstetrician, we're always balancing between the patient and the baby. So here, even more than, most of the other conditions. So the hypertensive emergency management applies to all forms of hypertensive disorders like chronic hypertension, gestational hypertension, preeclampsia with or without severe features. So you have to keep in mind, if the systolic blood pressure is more than 160 or diastolic is more than 110, you really have to repeat the blood pressure within 15 minutes. And if the blood pressure remains within the severe range, treat with about 30 to 60 minutes, ideally as soon as possible, but don't wait to treat the hypertensive emergency in your ward or in the clinic. So the American College of OBGYN actually talks about the antihypertensive agents, which I think are the same that you use in your clinical practice. We go for labetalol. Usually that's our first line, 10 to 20 milligrams IV, then 20 to 80 milligrams every 10 to 30 minutes to a max of like 300 milligrams. We can also do a constant infusion, 1 to 2 milligrams per IV, but in our facility, we can't do IV infusions of antihypertensives unless they're in the ICU setting. Hydralazine, 5 milligrams IV or IM, this acts pretty quickly. And then nifedipine, oral, you can actually do 10 to 20 milligram orally. So we usually do labetalol or hydralazine because you can see the onset of action is about 1 to 2 minutes for labetalol and 5 to 10 minutes for nifedipine. So we try to stagger between the two, and we keep the hydralazine as one of our third options in our delivery room. So, controlling blood pressure is the optimal intervention, right? So because we have to prevent the deaths due to stroke in women. So this is one of the most important intervention that we can do. The other life-saving thing in the management of hypertensive disorders is the magnesium sulfate. So any preeclampsia with severe features or even severe gestational hypertension, meaning absence of proteinuria, but severely high elevated blood pressure, we use magnesium sulfate regardless of the classification of the hypertension. But it's not universally recommended for preeclampsia without severe features. So I think it depends on your practice, availability, and, is it even like worth doing magnesium for those who don't have severe features? But it really depends on case-by-case basis. So there is no blanket statement that our professional organizations provide in terms of the MAG sulfate. And the main thing why we use MAG is for two reasons: seizure prophylaxis, significant reduction in the eclampsia, and then control of hypertension with the labetalol, other agents. So you kind of do both. And that's even during the labor, the intrapartum management, those are the two main things that we do, is the seizure prophylaxis and control of hypertension. So magnesium and the antihypertensives are like the most important things to have in your toolbox in any of the labor room facilities. And during labor, what we usually do is we do hourly blood pressure for those who actually have non-severe ranges, but those who have severe range blood pressures in our unit, we actually do every 15 to 30-minute blood pressure checks, because we worry that if it's persistently in the severe range, we actually may develop eclampsia for our patients. So any hypertensive emergencies, we try to manage as soon as possible. In the labor, hematological monitoring is kind of as needed, like avoid loading with fluids for these patients, and operative delivery if severe blood pressures or you're not being able to control. So that's what we usually do for the intrapartum management. It's always the $1,000,000 question: what should be the mode of delivery, right? Should we do C-sections for all? Can we induce patients with these hypertensive disorders? I think the mode of delivery should be determined by the routine OB indications for the most part. However, for those with severe features, you really have to think about case-by-case basis, and also the gestational age at which we are diagnosing it. The chronic hypertension, gestational hypertension, and preeclampsia without severe features, we always attempt induction of labor and we attempt vaginal birth. But how the disease is progressing and what's happening on an hour-to-hour basis may determine the need for C-section sometimes. So here, it's not an automatic C-section unless their platelets are kind of going down really low. You worry that it further worsens the condition, or like unstable mom or baby. So, once you stabilize, you kind of move quickly towards the delivery. We always have to have a quick talk with our anesthesia folks when we are dealing with people with hypertension. So it's always good to think about some of the anesthesia care and evaluation. For example, the epidural or spinal anesthesia is actually preferable compared to general anesthesia, because not only general anesthesia has higher risks of aspiration and other complication, induction of general anesthesia may also sometimes precipitate seizures. So you have to be really careful and probably talk to your anesthesiologist if you're, doing a C-section or anything, just to see if they could do it under, regional anesthesia. However, as we know, that epidural hematoma can happen when the platelets are lower. So those with severe preeclampsia usually have low platelets. So in my facility, the anesthesiologist would want like a stat hemoglobin and a platelet to double check on the platelet number. And they usually don't recommend giving spinal anesthesia if the platelets are less than 70, because hematomas are pretty common in platelets less than 70. But this number, which is like less than 70, may vary depending on where you are. Not every anesthesiologist will be comfortable doing an epidural. In platelets, some may say, oh, we won't do anything for 100. I've seen 120. So it's really dependent on the comfort of the anesthesiologist. So we have to talk to them and make sure they feel comfortable. If they're coagulopathic, absolute contraindication. Sometimes, it develops into abruption and DIC, the hypertensive disorder. So you have to be really careful in terms of like offering the regional anesthesia. And also remember, magnesium sulfate can prolong the duration of non-polarizing muscle relaxant. So you have to warn the anesthesiologist if the patient is on MAG and let them know so that they can choose the right anesthetic for the patient. And once you deliver, we talked about the interpartum care, we talked about the anesthesia care. So the postpartum blood pressure measurement is also equally important. Just to give you an example, in our facility, in our hospital, we used to have like 12% of the patients who we discharged home would actually come back with severe range blood pressures. The aim was always to keep the blood pressure less than 140 or 90, but there is a peak somewhere in like day 5 and day 7. And there were a lot of readmissions that were happening in our hospital in the postpartum period. So we instituted a process in which we actually aggressively started treating the hypertension. So anything above 150 or 100, we started putting them on antihypertensives, or we continued the antihypertensive treatment if necessary. And we made them come back in like 1 week for blood pressure checkup and another review in 6 to 8 weeks. And then if at 6 to 8 weeks, the blood pressure was still elevated, we had to send them to a GP, like a general practitioner, for continued management of the hypertension, because now we are entering the realm of the chronic hypertension at this point in time. So once we actually instituted aggressive postpartum hypertension treatment, our readmission rates, like people who came back to the emergency room and had like more than 140 or 90 or like severe blood pressures, actually reduced to like less than 2%. So our readmission rates are extremely low at this point in time. So, aggressive management of the postpartum patient, making sure that you don't kind of forget checking their blood pressure, because they are equally at high risk for, the seizures and stuff in the postpartum period as well. So one of the things about chronic hypertension, when we talk about management, is also the weight management, right? So if someone in the earlier part of the pregnancy has like chronic hypertension, maintaining a healthy goal of weight, like exercising, telling them to exercise a bit, eating healthy, some low salt diet, these things are all extremely helpful. There was always a question of, should you offer antihypertensive therapy? Should you not? So there's definitely reasons to kind of keep the blood pressures in the 135 over 85 range. And also aspirin, 75 to 150 milligrams once a day from 12 weeks. So I think in India, you get 75 milligrams of aspirin, baby aspirin. We actually have 81 milligrams of aspirin in the United States. So once a day is usually really recommended to, prevent preeclampsia in these patients. But I think you all know about the CHAP study. This is an open label, multi-center randomized trial. We had about 30,000 patients. They were screened. And, it's a huge, large center study. And the people were randomized to get either antihypertensive therapy for blood pressures of 140 or 90 over, or, just expectant management. And the study found like a reduced risk of primary composite outcomes such as preeclampsia with severe features, medically indicated preterm birth, less than 35 weeks, abruption, or fetal or neonatal death. So now the American College of OBGYN, as of last year, 2022 April, strongly suggests like starting someone on like antihypertensives if their blood pressure is like consistently higher than 140 or 90. And this is only for chronic hypertension, not for gestational hypertension. And those with chronic hypertension, we also do some baseline evaluations, such as we get like baseline AST liver enzymes, baseline serum creatinine, baseline potassium, baseline urea nitrogen, complete blood count, and a 24-hour urine or a spot protein creatinine ratio. Because in case they do develop preeclampsia in the future, you probably need to differentiate that from like their baseline. And we also get a baseline EKG for all the chronic hypertension patients. And those with chronic hypertension, if you need antihypertensive agents, we usually start them on labetalol. It can be anywhere from 200 to 2,400 milligrams per day, usually in 2 to 3 divided doses, or nifedipine, 30 to 120 milligrams per day. You could do the extended release tablets. Methyl-dopa and hydrochlorothiazide are kind of our last choices. We usually stick between labetalol and nifedipine. So those are some of the main agents for chronic hypertension. For all chronic hypertensives, we do ultrasound and growth assessment once at least between 28 and 36 weeks. We don't know how frequent we need to do, but sometimes some people do every 6 weeks growth ultrasound because chronic hypertension is known to cause some growth restriction. And then we don't do routine umbilical artery Doppler velocimetry here, but I think in some parts of the world, everybody with hypertension gets like routine Dopplers. And then the non-stress test or cardiotocogram, it's really dependent. For example, the American College of OBGYN says, do it weekly. We do it starting like 32 to 34 weeks until we deliver them. And the NICE guidelines from RCOG actually says, do it if clinically indicated, not always necessary to do that. So if we really think about the delivery timing for chronic hypertension, usually we deliver them by 39 and 6. So by their due date, we try to kind of make sure if they're not delivered yet, either induce them, and if they've had like other indications to offer a C-sections, like a prior C-section and such. Those with well controlled on medication, you can anyway go from 37 to 39.6. I guess, really depends. And those with frequent medication adjustments, you may want to be done by 38 weeks because their risk of preeclampsia and preeclampsia with severe features on top of chronic hypertension can be extremely high. So the preeclampsia with severe feature, with the preeclampsia with gestational hypertension or preeclampsia without severe features, we kind of talk about expectant management, like observation without, for those without severe features, and expectant management until 37 weeks is really recommended. And we do antenatal testing weekly in the United States, but not always in other parts of the world. And definitely some serial growth ultrasound if you diagnose it early in pregnancy. Same lab test that we talked about, home blood pressure monitoring, symptoms monitoring, if they're reliable. And usually induction by 37 weeks is really beneficial based on this HYPITA trial. So we do expectant management up until 37 weeks for gestational hypertension or preeclampsia without severe features. For those with, preeclampsia with severe features, we have to be really careful because if we're doing expectant management, that might be just to kind of give time for corticosteroids, like the steroids to expand, promote lung maturity. MAG, if they have, definitely to prevent seizures. But before 34 weeks, we really do expectant management for better neonatal outcome because we don't want to bring in preterm babies. But it has to be a good shared decision-making between the patient, doctor, your pediatrician and neonatologist, what's available, and the risks for mom and the baby have to be really discussed, and a very close ongoing surveillance in the inpatient world and delivery if there is any deterioration of the maternal or fetal condition. But who are not great candidates for expectant management for preeclampsia with severe features? Those with abnormal fetal testing, fetus without like expectation for survival at the time of maternal diagnosis, like those with lethal anomaly and such, and persistent reversed end diastolic flow on the Doppler. Those are kind of contraindications on the fetal aspect. And on the maternal aspect, if you're trying everything, the blood pressure is not coming under control, epigastric pain or right upper quadrant pain, despite giving all the analgesics, persistent symptoms, stroke or HELP or pulmonary edema, eclampsia, or suspected acute abruption in the absence of placenta previa, you probably should not be doing expectant management, even if they're preterm, in those with preeclampsia with severe features. So these are some of the general guidelines from the American College of OBGYN in terms of the preeclampsia with severe features management. With the HELP, I think delivery is usually very imminent. You may have to, refer them to the tertiary center. But the steroids for HELP, like usually there's no good data on it, but definitely follow up on the labs on the post-delivery to make sure all the platelets and elevated liver enzymes are coming back to normal. With the eclampsia, the treatment is just magnesium, but basic supportive measures, I always tell my students about like, making sure that the ABCs are met, like airway, breathing, circulation, prevention of maternal injury, prevention of aspiration, oxygen administration, monitoring the vital signs, and transient fetal heart rate changes just to double check. And once you stabilize mom and the baby, it's the delivery, right? It's not an absolute indication for C-section, but most patients with eclampsia will end up with a emergency cesarean section. Seizures that are refractory to magnesium, always good to remember that we can do sodium amobarbital or phenytoin. And you may need sometimes endotracheal intubation and assisted ventilation. So once you start seeing someone with an eclampsia, calling an anesthesiologist to help with intubation and stuff might be really important for those. So if we were to think about the delivery timing, at least from the American College perspective, for plain gestational hypertension or preeclampsia without severe features, we deliver by 37 weeks, or at the time of diagnosis if it's after 37 weeks. Preeclampsia with severe features and stable maternal and fetal conditions, 34, or usually at the time of diagnosis if it's after 34 weeks. Preeclampsia with severe features, unstable maternal or fetal condition, or HELP syndrome or eclampsia, you stabilize the mom, you make sure the blood pressures are under control, and you deliver soon after the maternal stabilization. This is the summary. I know this is a busy slide, but ACOG actually has a committee opinion that actually talks about all the different hypertensive disorders of pregnancy and the suggested and specific timing. We have even an app like wherein you can actually put in their gestational age and it tells you when to deliver a patient based on the diagnostic criteria. But I think overall, we have to make a clinical judgment. These are just guidelines supporting it, but case by case basis, this may differ on a day-to-day basis. And we need to make the best clinical judgment, keeping both mom and the baby in the mind. So the summary includes 5 key elements, right? We have to recognize the symptoms and diagnose hypertensive disorders of pregnancy. We have to control the blood pressure with antihypertensives. We have to prevent seizures with the magnesium, and the delivery by 37 weeks for those with preeclampsia without severe features or gestational hypertension, or by 34 weeks for those with severe features. You may take the severe features a little later too, depending on your availability for NICU and ability to resuscitate or sustain a 34-weeker, or referral as needed is really important. And it doesn't end there. We have to keep a postpartum surveillance of these patients, because most of the patients who we deliver and send them to the postpartum ward, they may develop seizures or severe preeclampsia if we don't kind of monitor their blood pressures and follow up. Right. And as I mentioned, the last few minutes, I just want to show you some of the toolkits. So these are like from the CMQCC, which I told you. So these are some of the toolkits. This is what it looks like. These are freely available on their website. So if you're interested, so this is like the abnormal maternal assessment. So it kind of gives you like, what to do. This is the suspected preeclampsia algorithm. So, it kind of takes you through. I'm sorry, my computer is going faster than myself. You also have like acute treatment algorithm, like what to do if you have, if you have like acute hypertensive emergencies. Even, for example, you can see here the treatment recommended for sustained systolic and what to do with the labetalol, hydralazine, nifedipine. So almost like pathway for each of them. And then the acute treatment algorithm for eclampsia or magnesium sulfate and the eclampsia treatment. So these are all like some of the things that the CMQCC actually hosts in their website. It's pretty much like you can get it like, you don't need you just create an account with the CMQCC and you can access all these algorithms. So I strongly encourage, for those of you, you can go to the CMQCC website and you can get these algorithms for your practice. So with that, I think we have about 10 more, 15 more minutes. So I want to pause here and see if anybody has any questions, and we'll go from there.
Thank you so much, Aparna. It was such a simple and eloquent flow of deliberations, and people have really enjoyed it. There are plenty of questions, but I'm going to ask it in a manner of rapid fire, because otherwise I can't
Sure.
let you go to the clinic on time. So there is Meenakshi from Mumbai who has asked whether you prefer to give magnesium sulfate intravenous or IM. That's a question, though we know that the government recommendation is the standard 4 grams IV and 5 grams into each buttock. So it's both IM and IV as the loading
Right.
dose. But
Yeah.
this is a question she has raised. So your response.
Well, I think it really depends on whether you can get an access immediately. And if you have the ability to get an IV access and, loading dose and follow up, you could do that. But if you're doing it in an emergency scenario and you don't have an IV access, we usually do the intramuscular treatment at that point in time.
So also the follow-up question is, what is the best regime to be followed? Can you just tell? So as you said, I think whatever is possible.
Right, exactly. We do 4-gram loading followed by like an infusion, but again, whatever you have in a reasonable amount. But I would say this for all the emergencies. I think, if you are an obstetrician, if you are delivering someone, you have in your mind an emergency drill, and that's what we all get trained to, right? Like in United States, they everybody gets trained to, what do you do when this happens? Like million times you run that through your drill, so that when a real emergency happens, it's like you become a robot and you kind of say, okay, this is the next one, this is the next step. So you make what's available, you kind of keep an emergency drill within your brain, and then you go through that if anything be needed. And I hope you never need to do that.
And also another question about, can hypertension in pregnancy cause hypertensive retinopathy?
Very rare. We actually had a study because one of our maternal fetal medicine experts actually conducted an eye exam on all the hypertensive patients for about 1 year to see whether there was any retinal changes or whether there was any onset of early onset retinopathy and stuff. So there were some transient retinal changes that were happening, but not enough to warrant a routine eye exam. So the studies haven't shown that it's that prevalent, but can it happen? Definitely. I mean, there are some crazy case reports that you can see any day. But we actually did a study and it was not a routine, feature. So that's why I think at this point in time, we don't recommend routine eye exams for those with hypertensive disorders of pregnancy.
Right. Thanks, Aparna. Akshay, again from Mumbai. How often should we ask a patient to monitor the BP at home? These are simple but very practical, relevant questions.
Right. So we send them home we actually have a fact sheet about how to check blood pressure, how often to check blood pressure, and what are the things to remember when they actually check it. So we tell them to do it at least 2 times a day, once in the morning, once at night, when they're not super stressed, once they wake up, sitting up, at the blood pressure cuff at the level of the arm. Some people do 3 times a day, but at least twice a day is important if they could do it on their own.
Okay. And then this question is about, for how long should pregnancy-induced hypertension persist to be diagnosed as systemic hypertension?
Right. So we usually say by 6 weeks, most of the, pregnancy-related changes in the body are pretty much reversed. So at the end of the 6 weeks, if you're seeing someone with really kind of, higher blood pressure, I usually tell them to keep monitoring it for 3 months. So by 3 months, if they actually still have it, it's probably good to think about, is this some kind of, essential hypertension that's actually happening, and have them talk to their general practitioner just to keep an eye on it. I mean, they may not start them on antihypertensive, they may not do anything, but these are people who are at risk for, lifelong hypertension, and there goes our, lifelong care, right? So we might be diagnosing someone with hypertension or diabetes. In the event of gestational diabetes, the same, right? The diabetes. Absolutely. So you have to keep those things in mind and follow up them more closely. And, their ends are territory because we have more pregnant patients coming in to take care of. So you probably have to transfer them to someone who can actually take care of these hypertension and everything on a, routine basis.
So this is again a ground reality question, Aparna. When you say 3 months, we usually grumble that for follow up, they don't come. Even 6 weeks, they don't come. After that, also, they don't come. But I heard on very many forums that this is not only in low middle income countries, but even in high income countries, the follow-up rate is not as good as one would
Very
expect.
true. So I think most of the postpartum interventions that we actually tend to do has to probably be in conjunction with the immunization visits or like pediatric visits, and maybe empowering some of the, those general practitioners or pediatricians who actually take care of the baby to treat like the mom and baby as a dyad. Because it's very unfortunate, like in the United States, I feel like that's one of the biggest disadvantages, that the care is very fragmented at times. Like I
Silos,
don't
yeah.
see the baby, the pediatrician won't see the mom, and there is like a really disconnect between the two. But now they're actually having care models where there is a newer specialty called MedPeds, which is medicine pediatrics. So they take care of adults as well as pediatric population. So that newer specialty is gaining a lot of popularity in here, because they can actually do both mother and child like follow up throughout the care. And that probably needs to happen everywhere, because the moms don't show up. I mean, in the private facilities, I think our postpartum follow-up rates are pretty good. Like we have about 70-80%, but in some of the other, public sectors, it's really hard for mother to focus on. I mean, I think the motherhood makes you also like not want to focus on you and focus 100% on the baby. So emphasizing that it just doesn't end there. They have to come back, or checking up with the pediatrician or like the immunization visits to make sure there is a component of maternal evaluation over there as well. And that can be used for so many different things: contraception, hypertension evaluation, diabetes evaluation. So many things can happen with the, newborn evaluation time for the mom.
Yeah, interestingly, there's one more new model that in rural India it is being tried, because these ASHA workers go home to home and they have a very, very close rapport with the patient. So they are now being sensitized that those who they bring them in for delivery and they are noted with high blood pressure or high sugars need to be monitored for long term. So
Yeah.
it is in their armamentarium. They take a glucometer, they take a digital BP apparatus, and home to home. So she need not come back either to maternity home or the pediatrics, but we reach out to them. So this is also working out to be more, robust model with the patient.
And I'm sure the community workers also take care of the immunization part for the children, right? So I think that's the type of the model. It's hard to expect that from, from a urban, fragmented care facility, but I think that's actually ideal. Even if we can do it like, in every facility possible, is to have some healthcare worker to evaluate both mom and baby as a dyad, and then check everything for both. So that's amazing.
There are 3 or 4 very, very rapid questions. You mentioned low salt diet for chronic hypertension. Do you give that same advice for pregnancy hypertension as well?
Well, I tell them it doesn't hurt. But is there studies to show that this diet actually changes your, your ability to get severe hypertension? Or, I mean, we don't think so, right? Because pregnancy is doing this in terms of gestational hypertension, preeclampsia, whereas chronic hypertension is kind of a pre-existing process that you're trying to avoid, worsening of it. So probably not, but is low salt diet a good thing overall? Yes. So eating healthy and eating more like, vegetables and like less of like salty and other things may be better during pregnancy. There was this recent study, it said Mediterranean diet is actually really good. But I was like, I'm sure any diet is good if you actually have a balance of it. There's so much of like, culturally, India has so much of like, oh, do this is good. Do this in postpartum, that's good. And I'm sure all those things have very valid reasons why each culture does something during pregnancy and postpartum. However, I have started to believe that eating for 2 or eating a lot or like, that probably may not be the ideal way. And reduction of salt may be good. We don't know yet.
Oh, okay. So 1 or 2 last questions and I'll let you go. for prediction and prevention, FIGO has its own advice of the history, the mean arterial pressure, the uterine artery Doppler, and the biochemical markers. But many setups in India are moving with the gestosis score. So oftentimes they have been told that there's not enough evidence, and therefore it has not come into the global advice. So what is your take on that? Should
we don't do it, because I think, whatever, happens, I feel like in the United States, things are a little bit slower to kind of do like adapt things very quickly. So the risk scoring system for the preeclampsia, which is your gestosis score, we actually don't do that. We also don't do the first trimester uterine artery notching or like all those things. Nothing. We simply kind of do the risk factors. If they have more than 2 risk factors, we start them on baby aspirin, which is 81 milligrams, which is your 75 milligrams. And we follow them clinically, and we've done okay. I mean, but any score to me is usually useful for those who actually, you have so many patients. And if that's one part of your initial assessment, you get a score and you're more careful.
Yeah,
sure. I mean, I'm all up for being careful for patients who seem to be high risk, but we just don't use it on a routine basis here.
Okay, great. One very, very last question. There's so much happening around gestational diabetes, and then we've said that pre-gestational also, and then many of the PCOS patients, obese patients, glucose intolerance. So very recently in one of the major conferences, it was a panel where 2 out of 4 panelists said, because GDM and preeclampsia are like comorbidities, for whomever we find the glucose intolerance, we do 2 things as a routine. We start them on aspirin as a blanket, because she may develop preeclampsia. There's a high chance. And we always give the steroids, because there's always a chance that she may end up with the early delivery. This has, there was a lot of argument that this is, so empirical and so wide, and you're just...
Well, I agree with baby aspirin because it's just 81 milligrams of aspirin. I have a feeling that 10 years down the lane, every pregnant woman will probably just take baby aspirin along with prenatal vitamins in the beginning. We know it doesn't harm anyone. We know there is some benefit. So maybe baby aspirin is not a big deal. And I agree. I actually do that. If I diagnose someone with gestational diabetes, I actually tell them, start a baby aspirin, because I diagnosed them around 24 weeks. And who knows? I mean, that's the time when you start like developing preeclampsia is like 28, the 3rd trimester. So I start them on baby aspirin. Steroids, I mean, what's the point in giving steroids until the delivery is imminent? Because you give the steroids now, and what if they don't deliver for another? I mean, it's just not, and it's intramuscular. It has consequences. It can make your glucose go up. It can, it can change other things. So I don't believe that it's, it may be a routine that we would do, because we can hold these preeclamptics if they're not severe up until 37 weeks. But at any time you feel like, this is worsening and the delivery may be imminent, definitely. I mean, we always err on the side of giving the steroids for the pretermers. But a routine steroids, I don't know if that's going to ever come to picture, but maybe routine aspirin for gestational diabetes is not a bad idea.
A new question has just come up. They say that starting aspirin before 16 weeks is what the FIGO advice says, which it is better. So Dr. Aparna just said that at 24 weeks, if she diagnoses, she will give, because the comorbidity. What if it's a glucose intolerance pre-pregnancy?
That's only in the setting of
start them with the first trimester itself? That's a question.
Yeah. I mean, if you have risk for preeclampsia, we start at 12 weeks, actually. That's the routine. But I'm just saying that if you didn't start someone on aspirin and you diagnose them with gestational diabetes later, fine, start it at that point in time. Does it really gonna matter, help? We don't know yet, because these are all like, you can call this expert opinion at this point in time, because the data does not like show.
I just want to add here, we do this gestosis score. So gestosis score definitely helps when to start, which patient can we start aspirin. And we did study here. And so that will really help, and we can categorize in which patient we can start an aspirin.
Yeah, I mean, just to clarify, we have our own screening system too. So just like the gestosis score, so every patient at intake, you assess their risk of preeclampsia. If they are at risk for preeclampsia, or if they are chronic hypertensives, start them on baby aspirin at the end of the first trimester. Definitely helpful. However, if that person was completely normal, and let's say they develop some things later, which may put them at predisposition for preeclampsia, should we start them on the aspirin, 75 milligram or whatever the dose is? That's still questionable, but I would say I don't think aspirin hurts. And so there's,
better
it's
on the
oral
safer
medication.
side,
It's not that expensive. So I think that may not be a bad idea.
Yeah, excellent. See, as you said at the beginning, Aparna, though this is such a common topic, it needs to be heard again and again. We have a large number of delegates who are thanking you on their behalf, and many, many, many simple questions all around. It's the same jumble going on. There are still about 20 more questions, but I have just, plucked out the most practical and the most relevant
These
ones
are
to have.
really important. And I think all of us as obstetricians, we can't escape hypertensive disorders of pregnancy. And that's, I was trained like in part of like United States, where every patient that came through the unit had it. Like it was kind of so rampant. And even now in my practice, I have Indian patients, I have Asian, Southeast Asian, I have African American, I have Caucasian. It does not spare anyone. And the color of the skin and how you look may be very different, but the blood pressure actually goes up higher in every part of the world, in every part of in every ethnicity. So I'm glad all of us are on the same page. And I just wanted to bring in a different perspective. And I hope this was useful.
It was very, very useful. And thank you so very much on behalf of all those whom you can't see. And they have all appreciated immensely because, one little point they take back in practice, and it really makes a lot of impact. The topic is such, both your, passion areas, the contraception and the hypertensive disorders, which you spoke so brilliantly today. So I think it's really, really the time well spent, and we should thank you again.
Thank you, Dr. Emma, and thank you, Dr.
Closing,
Vidya and everyone.
Vidya and Rajeshri, if you want to just make closing comments. Aparna has only 1 more minute.
Yes, Rajeshri, are you audible?
Yes, ma'am. Yes, I just logged in, and it's a beautiful presentation that I could catch up with some points of role of aspirin and how important it is to screen the levels. I'm in Heathrow right now, just trying to catch up with the talk which was going on now. Excellent talk. Hearty congratulations again for bringing up such wonderful day-to-day relevant topics in clinical practice, because every time we think of hypertension, we always are at a challenge that we never know when the lady flares up and becomes worse, and how best we can do to reduce the morbidity and mortality both for the mother and for the child. Thank you so much.
You have the Indian audience across the globe.
That's perfect. I'm always, I feel myself as a global, citizen now.
As a closing remarks, I must say that it was really informative for everyone, right from the postgraduate to the consultants. It was really, and it gave a very clear idea about how to manage. That was the gist of your talk, what I must say.
Thank you, Dr. Vidya.
Any really questions anybody wants to interact with you, you can just share your email ID.
Definitely. I'm going to put this in the chat that you can definitely email me. Happy to kind of follow up, and, I'm happy to come back and talk about another topic. And also, anybody who you send them home, always talk about intraconception care and give them a little contraception so that they don't get pregnant immediately, and they can fix all the things and then come back in 18 to 24 months.
And those flowcharts also we can just take from.
Yeah, you can download in the, it's called CMQCC. I'm putting it in the chat, and those websites, they have really good, data, because California has done a lot to decrease the maternal mortality. The United States maternal mortality is about 17 or 18, and California is 6 per 100,000. So it's kind of drastically lower. So the things that they've done here are, useful for any part of the world.
Yeah. So once again, a heartfelt thank you to Aparna, and we hope to cross each other's path very, very soon.
Very soon, yes.
In India too. Namaste. And the organizing team, Kasoga, KCOG, Artist, Shield, and Medisage, and all the delegates, on all our behalf, we once again thank Aparna Sridhar, a very brilliant and distinguished speaker for this evening. Thank you very
Thank
much.
you.
everyone.
Thank you. Thank you very much.
Bye.
Thank you.
Thank you. Bye-bye.
Thank you, ma'am.
Thanks so much.
Thank you, ma'am.
Yeah, thank you.